Welcome to the deep dive. Today we're really getting into atrial fibrillation, AFib. It's the most common irregular heart rhythm out there. And our goal today is to kind of move past just the basic definition. We want to understand the electrical chaos, what goes wrong mechanically, and the big shift happening now in treatment.
Absolutely. And that chaos you mentioned, that's really the defining thing here. Because you look at other fast rhythms like atrial flutter or SVT, they're fast, yes, but they follow predictable electrical circuits, structured.
Where they have a pattern.
Exactly, AFib.
Yes.
It's just total electrical disorganization. The upper chambers, the atria, they're getting bombarded with these chaotic signals. So instead of a coordinated contraction, they just quiver really fast, often over 300 beats per minute. They just can't squeeze effectively.
And that difference, quivering versus squeezing, that's the core mechanical issue, isn't it? The loss of atrial kick.
Precisely. Normally, you get this final timed push from the atria just before the main pumping chambers, the ventricles, contract. It talks them off.
The last little bit of blood.
Yeah, that kick. And when you lose it in AFib, the impact on the heart's efficiency is pretty dramatic. We're talking a potential reduction in cardiac output, how much blood the heart pumps out by as much as 30%.
30%? Just from losing that kick. Wow.
It's significant, and that's why patients feel so tired, so short of breath, that dyspnea. It's a direct result of that mechanical inefficiency.
Okay, so inefficiency, fatigue. But what's the really critical danger we need to watch out for?
Stroke. Without a doubt, ischemic stroke. If AFib isn't managed, the risk goes up about 5 times. And the reason is straightforward, really. If the atria are just quivering, blood doesn't move through properly, it pools, it stagnates.
And stagnant blood clots.
Exactly. And here's a really key point from the research. Over 90% of these dangerous clots, they form in a very specific place.
That little pouch, right? The left atrial appendage.
The LA. Yes, over 90%. It's quite startling how localized that risk is.
So knowing that, how do we figure out who needs serious stroke prevention?
That's where the CAH-ARO VASC score comes in. It's absolutely crucial. It helps us tally up risk factors, things like age, hypertension, diabetes, prior stroke, the HASV in the score. And these factors often point towards underlying structural heart disease, what we call atrial cardiopathy.
So the score tells us it's not just about the AFib episode, but the underlying health of the atrium.
Precisely. Which is why even short, infrequent AFib bursts can warrant anticoagulation if that baseline risk score is high. And we also have to think about other drivers, things like obesity, high blood pressure, and especially obstructive sleep apnea, OSA. They fuel the fire.
Okay, that makes sense. Let's shift gears slightly. Where does this electrical chaos actually start, the trigger point?
Yeah, so the initiation, it often begins with rapid firing from these little muscular bits that extend into the pulmonary veins.
The veins bringing blood back from the lungs.
That's right. Those entry points into the left atrium can become electrically irritable, acting as spark plugs for AFib.
So that's the spark. But what keeps the fire going? You hear this phrase, AFib begets AFib. What does that mean?
It means the AFib itself changes the heart. It leads to remodeling both electrical and structural. The atrial tissue can change, maybe develop scar tissue, or its electrical properties degrade. This makes it easier for the next AFib episode to start and harder for the heart to get back to a normal rhythm.
So it's a vicious cycle.
It is a positive feedback loop. That's how AFib progresses, from paroxysmal, where it comes and goes on its own, towards persistent and sometimes even permanent AFib.
And understanding the progression really explains the big shift in how we manage it now.
Definitely. We always have 2 main goals: prevent stroke, obviously, and then stabilize heart function. That used to be a debate. Control the heart rate or control the rhythm.
Right, rate versus rhythm control.
But the newer evidence, it strongly supports going for rhythm control, restoring that normal sinus rhythm, and doing it early.
Why the push for early rhythm control?
Because getting back to normal rhythm reverses those bad hemodynamics we talked about, that lost atrial kick. And crucially, it helps prevent or slow down that harmful remodeling, that AFib begets AFib cycle.
Okay, so how do we achieve that? What's the go-to intervention?
For many patients, the advanced approach is catheter ablation, specifically pulmonary vein isolation, or PVI.
Targeting those trigger points in the pulmonary veins we mentioned earlier.
Exactly. The procedure uses energy, either heat or cold, to create tiny scars around the openings of those veins. It electrically isolates them, building a sort of firewall so those chaotic signals can't get out and trigger AFib in the rest of the atrium.
And this isn't just experimental, right?
Oh no. PVI is now a Class 1 recommendation, the strongest level of evidence for rhythm control in suitable patients. That includes patients who also have heart failure, where restoring normal rhythm is particularly beneficial.
What about diagnosis? How do we even catch this, especially if it's intermittent?
Well, the standard is still the ECG, the electrocardiogram. But for intermittent AFib, you need longer monitoring, like with a Holter monitor. But what's really changing the game is wearable tech. Smartwatches, other devices, they're getting really good at non-invasively screening for AFib. High sensitivity.
So, like, your watch might pick it up?
It might flag it, yeah.
Yeah.
You still need a proper medical ECG to confirm the diagnosis, absolutely. But for early detection and screening, it's a huge step forward.
Okay, so wrapping this up, what's the big picture for someone listening?
I'd say AFib is clearly a progressive disease. Managing it effectively needs a comprehensive strategy. That means rigorous stroke prevention based on risk, aiming for early rhythm control, often with PVI to stop that remodeling process, and being really aggressive about treating those underlying conditions like hypertension, obesity, and sleep apnea.
It really sounds like it's about the whole system, not just the heart's wiring.
Absolutely. Which leads to maybe a final thought for you to consider. We've seen how AFib risk is so tied to underlying structural changes, that cardiopathy, and these systemic issues like OSA and weight. So, thinking ahead, could continuous monitoring with wearables eventually let us predict who's heading towards AFib before they even have that first electrical episode? Could we see the risk building structurally?
Predicting it before it even starts electrically, it's definitely something to think about as the technology keeps evolving. Thanks for that deep dive.